Okay. Patient safety. Can we afford not to do patient blood management? What is patient safety? Here's a nice definition. Patient safety is freedom from healthcare-associated preventable harm. A simple explanation is that when things go right, nothing bad happens. To maintain or improve patient safety, error has to be prevented, rectified, or at least minimized. If you look at the Canadian Patient Safety Dictionary, I'm sure John is familiar with that one, the reduction and mitigation of unsafe acts within the healthcare system, as well as through the use of best practices shown to lead to optimal patient outcomes. And you have a similar definition by the World Health Organization. Now, this is a landmark paper that started to create the awareness about patient safety. Interesting paper that estimated that among 2.6 million patients discharged from New York hospitals in the year 1984, there were 27,000 adverse events involving negligence. Many injuries are the results of substandard care. And here are some of the stats. About 7,000 of these patients died due to negligence. And that stirred up the medical community. And there was a time of the awakening. And the Institute of Medicine then came out with that book, First Do No Harm, by the way, so it's about safety. And then To Err is Human. And they identified the following problems. Errors are costly in terms of loss of trust in the healthcare system. More common, errors are caused by faulty systems. And healthcare is a decade or more behind many other high-risk industries. So that's about patient safety, and we come back to this. Now, let's turn to patient blood management. What is the rationale behind it, and how is it linked to patient safety? Blood management is connotated with donor blood management over 60 years, but opposite to the donor, there's the patient. So patient blood management versus donor blood management. Some people said, well, PBM is patient-oriented blood management. Well, every form of a medical intervention should be patient-oriented. So it's really more to make the difference between should we rely on the donor's blood or should we rely on the patient's blood. And I think it's well taken by this quote from Hugo van Aken and his colleagues, our own blood is still the best thing to have in our veins. Now, the new paradigm, patient blood management, is an evidence-based concept that's aimed at achieving better outcomes by relying on the patient's own blood, so it's outcome-driven. Here's another important element. It preempts and significantly reduces the resort to transfusions by addressing modifiable risk factors that may result in the transfusion long before the transfusion is even be considered. So it's a patient safety-driven concept as well. So now let's go to the rationale. We have 3 independent risk factors for adverse outcomes, apart from the underlying disease. And that's about patient safety. If we address a risk factor or multiple risk factors, it's clearly, due to the definitions we read earlier, a safety issue. Let's start with the anemia. Anemia, the literature clearly shows, is independently associated with morbidity, hospital lengths of stay, mortality. And the likelihood to be transfused in the anemic population is 2 to 9 times higher than in the non-anemic population. Here's this paper from Musalam with more than 200,000 patients, and it shows that even a small increase in the anemia results in an almost linear increase of mortality. The next factor is the blood loss, and about 75 to 90% of blood loss is surgical vessel interruption, and just a little bit, the remainder might be due to the impairment of the coagulation system. And then, of course, we have a plethora of literature that shows that red cell transfusion in itself is an independent predictor of adverse outcome. And of course, the anemia prevalence is heavily underestimated. We saw this from many studies, and also a lot of anecdotal evidence shows us that many clinicians think their patients are not anemic. But here we see there's depending on the patient population, a prevalence of anemia between 5 and 75%. So here, for instance, in cardiac surgery in the United Kingdom, more than half of the patients were identified as anemic. In Australia, even 71% in the male population of this patient population, and 56% in the female. And so if we have blood loss, then we either induce anemia or we increase the existing anemia. The existing anemia then triggers the transfusion. The transfusion, by the way, is obviously also triggering more of a blood loss, because more recent papers show that transfused red cells impair the coagulation system. And we identified in a large prospective observational study in Austrian elective surgery, including arthroplasties and CABG, that 97% of all transfusions are predictable by exactly these three modifiable risk factors. Is there anemia, and has it been treated? What's the blood volume that has been lost? Has that been controlled, or why hasn't it? Is the transfusion trigger liberal or restrictive? So knowing this leads us, to the strategic response for each of these independent predictors, which is the optimization of red cells, and you undo the first independent predictor. You minimize blood loss and bleeding with a whole armamentarium of possible hemostasiological surgical tools and techniques, and you can harness and optimize the physiological tolerance to anemia. So this then can be split in the pre, intra, and post-op phase, and then you have a 9-filled matrix based on the 3 pillars, and that basically includes most, if not all, of the available modalities of patient blood management. Now, you want to know probably to what degree is PBM now recognized? Well, we see a growing number of articles in major journals focusing on patient blood management. We even had, we've seen this year in the September issue of the AABB News, the American Association of Blood Banks, the growth of patient blood management programs, so it's been recognized to a degree. Here's the number of articles you find in the PubMed search as of October 29, and you can see that just in this year, and it's not finished yet, is the steepest increase of new articles. But it's also recognized on a higher, let's say, administrative level. In 2010, the World Health Assembly, which is the prime decision-making body of the World Health Organization, they endorsed patient blood management with a resolution. That's the resolution 6312, and it says clearly in this resolution, bearing in mind that patient blood management means that before surgery, every reasonable measure should be taken too, and then it basically tells you about the 3 pillars, and explicitly it also re-emphasizes in the resolution, this is the 3 pillars of PBM. And as a consequence, the member states are urged to establish systems to strengthen PBM, and the Director General of the World Health Organization is requesting that guidance, training, and support of all the 197 member states is being facilitated in favor of PBM. Then, as a consequence of this, in Dubai in 2011, there was the World Health Organization's Global Forum on Patient Blood Management. That was the first forum ever that made this the main topic in this huge organization, and they defined some priorities for action For instance, conduct multicentric studies and look at patient outcomes, which is part of the safety analysis. Focus on outcome research. Translate, make available current evidence through desk research, meta-analyses, and so on. Also, the United States authorities have reacted. The Advisory Committee on Blood Safety and Availability went through this resolution in June 2011, and the committee had a lot of very interesting recommendations to the government, including statements such as blood transfusion carries a significant risk that may outweigh its benefits in some settings and add unnecessary costs. Also, the biannual report of the United States Department of Health and Human Services, a report on blood collection utilization, has now, and this is the 2011 report just came out a few weeks ago, dedicated 5 or 6 pages on patient blood management, and is obviously aware that something is changing on the scene. Now we're coming to Australia. This is the website of the National Blood Authority of Australia. This is the federal agency, or the Commonwealth agency, that is responsible for the entire blood establishment, for the procurement of blood, for the safety of blood. And they decided to abandon the old product guidelines. So the product focus is now out of focus, and replaced it by 6 patient blood management guidelines. So they decided that a guideline cannot be based on a product, but has to start with a patient's problem and go from there. And when you look into they are downloadable, by the way. You can get them, all these volumes, on the web. They again explain the 3 pillars, and these are the 4 modules that are out so far. The next 2 modules is on OBGY and then pediatrics and neonates, and we expect them to be out in the next 6 to 8 months. So how do we get from PBM guidelines to the implementation? We heard already that 7% of physicians follow guidelines. So what needs to be done? Well, again, the National Blood Authority has now brought out this paper, which you can also download, saying National PBM Guidelines Implementation Strategy. And interesting, there's increasing evidence that there are risks to patients. Our topic is patient safety, right? Or allogeneic transfusions can be associated with adverse patient outcomes. And introduction of PBM can minimize these risks. So there's clearly a patient safety focus. Also, the National Accreditation Body for Hospitals in Australia, Australian Commission on Safety and Quality in Healthcare, they clearly said the establishment of coordinated PBM management programs will help organizations to attain accreditation. So in other words, if you don't have a PBM program in Australia in the future when you want to open a new hospital, then you fall short of the points you might need for a full accreditation. So do statewide programs exist and work? Yes, they do. One in Western Australia. It's a very unique country. Next hospital is 750 Ks. By the time you get there, you don't need a transfusion anymore. So they have their own website, and that's directed to the customer, to the client or the patient, to healthcare professionals, and also includes the administrators. You can download this executive summary of the government of Western Australia, and they clearly said we want to shift the focus, the paradigm, from a product to the patient needs. And the rationale behind their program starts with patient safety. That's, again, the topic. Also, a very interesting point, which is not my topic today, is cost, but I think we should look at this for a moment. Improving patient outcomes while reducing cost. This is a very, very rare situation in the healthcare system. Normally, better outcome means more investment. But here we get more for less. And also this brochure, Patient First, again, safety, consent to treatment policy for the Western Australian health system, and it has a very nice paragraph about blood products and the absolute need for an informed consent in the best sense of the word. So what are the results of that program that has now been from the starting point until now? We had about 5 years. Well, what you see here is the red blood cell issuance per 1,000 separations. You might say admissions probably, but the Australians count by separations. Since initiation of the program, the red bar is Western Australia, and the gray bars are the other jurisdictions in the country, New South Wales, Queensland, etc. So you see we have achieved the lowest issuance rate, and in an international context, blood collection utilization in Australia, Europe, and the United States. Here's the United States. We heard this already today, about 48 transfusions per 1,000 inhabitants. This is Australia compared to the US, and the black line is Western Australia. So we are now less than half of the per capita transfusion in Australia when you compare to the United States. That's an interesting slide. Red blood cell transfusion rates in hip replacement, knee replacement. This is, if we added the next 2 semesters, you would have a 0 and a 0. We have now reached a 0 transfusion rate, not just intraoperative, perioperative 0 transfusion rate. And what you see is that as the transfusion rate goes down, the complication rates go down. We see, of course, no hospital-acquired anemia anymore because we treat the anemia, we detect the anemic patients and we treat the anemia. So this is one of the expensive hospital complications according to the DRG system, and it has disappeared in this population in this hospital. And also post-procedural complications have decreased. What is not as well, every of the 4 we looked at have decreased, and we are working on a major publication to show this not only for knees and hips but across the whole program and the whole patient populations treated in Western Australia. Here's another program from Leeds in the United Kingdom. A PBM program resulted in a decreased prevalence of anemia from 26 to 10%. The blood loss reduction was significant. Transfusion rate for hips went down from 23 to 7%, for knees to 0. The length of stay was reduced by a day or more, and the 90-day all-cause readmission rate was significantly lower. And that's a very important point because there are now penalties in Europe for readmission. I don't know how it is in the United States, but when the patient gets readmitted within a certain time, and there's of course, some exclusion criteria, but then the cost remains entirely with the hospital. There's no reimbursement by the payers. So we think it's really one nice example that PBM is a win-win situation for the payer, for the patient, for the clinician. Then another very interesting study is from Inglewood, comparing outcomes of a cohort of patients undergoing isolated CABG within a patient blood management program group versus a propensity-matched group in other institutions without PBM. And in this program, these were the PBM strategies that have been applied. So you see pillar 1, 2, and 3 represented. And here are the results. The mortality in the PBM cohort was 0.8 versus 2.5. Serious complication 11.1 versus 18.7. And a transfusion was reduced by 75%. So in absolute risk reduction per 100 interventions, 1.7 fewer deaths and 7.6 fewer serious complications. Now, allow me a very rough and probably not too scientific extrapolation, but it gives you an idea what this means in terms of patient safety. What you find here is the statistic from the CDC, and it shows the number of discharges in the United States with operating room principal procedures. And we just want to look at the heart valve procedures and the CABG procedures. They were in 2010 about 275,000. Now, if we just assume that the United States has about the transfusion rate for these interventions as we had in the control group of the Inglewood study, which was the state of New Jersey, then we could say that doing PBM might result in 4,685 less fatalities and about 21,000 fewer serious complications. And now you can do this for every intervention. You can look at probably 2 million arthroplasties in the United States and calculate how many fewer nosocomial infections do we have. And a nosocomial infection costs about $15,000 to $30,000 to treat. So we are getting in the multi-billions of dollars. So the topic is patient safety. Can we afford not to do PBM? And if we come back to this definition, of course we cannot afford not to do it. We have identified 3 independent risk factors. We have identified a solution that leads to decreased mortality, morbidity, lengths of stay, and ICU lengths of stay. So PBM is really at the core of patient safety. Why then is the awareness still so low? Well, humans err. And we said already, the problems identified, more common errors are caused by faulty systems. And transfusion is for 60 years the default setting when we see a bleeding or an anemic patient. And the other problem is the confirmation bias, as it's explained by my dear friend Irving Gross. He says transfusions usually given to very sick patients. That's perception. Of course, if the patient dies or does poorly, we blame the underlying illness. When they improve, we credit the transfusion. But he says we don't question whether the transfusion contributed to their death in the first case or delayed their recovery in the second. So there are people saying, well, I was in hospital, I got a transfusion, and that's why I'm alive. In fact, he survived the transfusion. The next problem is complacency. For 60 years, physicians hear transfusion is effective, is safe, and is free. So why should I change? And the world-leading expert in change management is John Cotter from Harvard, sorry. Environment for complacency and maintaining status quo. He says we've got to defrost the hardened status quo, then we've got to introduce many new practices, and then we ground the changes in the culture. Now, people say, physicians still say, the database for PBM is so small, 70 articles, a few studies, one here, one there, no randomized controlled trials. How on earth should we have one, or some with the budgetary limitations? But what we could do is, instead of looking into the new paradigm, quickly do a look back in the old paradigm. In the old paradigm of donor blood management, look back on the old paradigm to establish a sense of urgency. Here's the poster you might be familiar with from the Australian Red Cross Blood Service. And they say it's a myth that transfusion is safer than it's ever been. It's true for some of the pathogens, but there are new infectious agents, and this paper shows that there is a lot in the blood pool, which has partly a theoretical risk, a very low risk, but some have are serious threats like dengue, like chikungunya. In the southern hemisphere, chikungunya has become a major, major problem for the blood pool. And then, of course, we have other problems. And so Harvey Klein summarized this not too long ago and said, as chief of the Department of Transfusion Medicine in the NIH, it's sobering to consider that if a new agent with a long silent carrier state and efficient blood transmission were to appear, the blood component collectors would be scarcely better prepared to interdict a transfusion-transmitted epidemic than they were during the early days of AIDS. But this is not really the problem of transfusions. It's not the inherent or the product risk. The much bigger concern, the real patient safety issue, is the outcome. And if you do a PubMed search on transfuse star and outcome star, you find almost 20,000 articles connecting transfusion and outcomes. And there were early signals, like this one from Neil Blumberg in 1996. More patients have died in any 1 year owing to transfusion immunomodulation side effect than died in the entire transfusion-transmitted AIDS epidemic. That's a very strong statement. But it went unheard because this was during the aftermath of the AIDS crisis, and this was just too much. Another inconvenient truth was too much to take. Has to do with the error, with the bias, with the complacency, of course. And then Bruce Spies said about 10 years ago, there are few, if any, articles that support transfusion actually improving patient outcomes. The majority shows the opposite. And a similar statement here on critically ill patients. You have heard already about the ICTO conference that wanted to understand more about transfusion and outcomes, and the enormous amount of literature we started with, and then we basically refined it down to about 500 papers with a paucity of evidence for the benefit of transfusion, but accumulating evidence for the harm of transfusion. And these are the outcomes associated with transfusion. I always say it's almost everything you can die from. And of course, these things lead to increased admission ICU, prolonged mechanical ventilation, lengths of stay, etc. And this is where the patient populations we came across in that study. Meanwhile, there's about 600 to 700 papers that clearly focus on transfusion and outcome as a primary or secondary endpoint. And the number of patients involved is more than 6 million. So the signal is really strong. Let's just pick one very quickly, cardiac surgery, because we looked at this in the Moskowitz study earlier. So in 2002, of course it's observational. The non-transfused did a lot better in a 5-year survival than the transfused. Then Gavin Murphy in his institution looks at a consecutive cohort of 8,500 patients, and he concluded red blood cell transfusions appears to be harmful for almost all cardiac surgery patients. He showed that composite infection was more than 3-fold and ischemia was more than 3-fold. So you would think that a transfusion improves oxygenation. What you see is an increase of ischemia. You get the opposite. Or look at the adjusted odds ratio for infection. If you get more than 9 units, your infections go up by 4,500%. Here's a very interesting paper from the Society of Thoracic Surgeons with 32,000 patients, and they just wanted to test the hypothesis that an increased peer risk profile of patient would explain the increased mortality. So they did what they used the PROM score. They calculated the patient's risk and stratified for this, and then this is the result. The crude odds ratio for mortality in the transfused versus non-transfused is 6 times higher mortality. But even when stratifying for the SPROM score, it was still 3 times higher. Then the propensity score match showed about 3 times higher, and the multiple logistic regression model. So there were 3 methodologies to show this as a very clear picture. There's more papers. This is from 2012 showing basically the same. 2013, risk-adjusted increase of 23% per unit on major infection. And so people say, well, that's all interesting, it's all nice, but we can't establish causality, it's just observational data. Well, this is true, this was in the past, but in 2012 we got here this paper that compared liberal versus restrictive with 19 randomized controlled trials, including 6,300 patients, comparing these thresholds. Here, the patient population. Of course, in the restrictive group, the transfusion rate was significantly lower, but most importantly, in-hospital mortality was significantly higher in the liberal group and in infection as well. So here is level 1A evidence showing that a liberal transfusion kills patients. You've seen this already, so we can skip this. Same picture, restrictive, a much bigger survival chance. Some of you might, this is the next thing, you know, another way of evidence, does transfusion physiologically do what it's intended to do? Here's this group from San Diego. I will skip this because of time reasons. That was an animal model. Now I have a human data. Some of you might have seen this. A patient bled down to 2.8 grams of hemoglobin, and he is well perfused, although it's not the ideal condition, but he gets then a 3-unit transfusion, and you can see that what you would expect is the transfusion improves, probably the circulation, the perfusion. The opposite is the case. It's sludging, it's clumping, it's a still stand, and of course it has an impact on the gas exchange. And when you look under the microscope, what happens in vitro over the 42 days of maximum storage time, of course this has a different flow property than ultra-fresh cells. And there's a lot of other things happening in vitro that has a potential impact on the recipient. Of course, immunomodulation, because you transfuse basically a biological soup, and if you get a second unit, you transfuse the soup of somebody else, so you have already 3 milieus, if you want, in your organism to battle one with another. Impaired microcirculation, most likely prothrombotic effects, compromised oxygenation due to the loss of nitric oxide, ATP, and 2.3 DPG, organ damage. Here's a paper from Lena Napolitano that shows that in very few studies, the oxygen that is taken by the tissue has increased, the VO2. In the majority of cases, there's no increase in VO2. So basically, transfusion doesn't do the job everybody thinks it does. So the other question then, patient safety, can we afford to transfuse? In the context of safety and quality standards, this is the European Medicines Agency, which is the equivalent to the FDA. Their main responsibility is protection and promotion of public health through the evaluation and supervision of medicines. Unfortunately, not the supervision of blood products. It's not under their jurisdiction. And basically is under nobody's jurisdiction. That's the interesting point. And so they have, for medicines, clearly this is the Tripartite guidelines, which is the FDA, the European agency, and the Japanese agency. They define what an adverse event is. So this is one that does not necessarily have to have a causal relationship with this treatment. So seen from this perspective, we have endless adverse events with transfusion. Adverse drug reaction means that a causal relationship is at least a reasonable possibility. I think we have clearly enough evidence to show that. And then serious adverse events or drug reactions resulting in death and life-threatening. I mean, we were talking about mortality in the major part of this presentation. So if you compare drugs, medical devices, and blood components, there are very strict regulations on the quality, except blood components. It's very vaguely defined what is a good quality product. The safety, it's inherently risky, is associated with adverse outcome. The effectiveness is extremely restricted. 88% of all patients are hemodynamically stable, receiving transfusions. They are almost all avoidable. And even in the extreme cases, we see successful management of profound anemia without blood. So this chapter is not closed yet. And the cost of these drugs before they really hit the market and get reimbursed are known for every drug, but unknown for blood. So we have different standards for the same patient. This is really on the safety side, and this is an enormous risk. So maintaining the status quo as of transfusion practice would not be accepted in the current context of quality and safety measures in the modern world. So what we are left with is, there is a paradox. We have this perception, transfusion is safe, transfusion is effective and beneficial, and is inexpensive. The evidence shows the opposite. So in summary, implementing PBM, you have to establish a sense of urgency, and I think we all have to look at the outcomes first. First, do no harm. And here is the final slide. The benefits of PBM programs, although we have not a lot data, this is the studies that are available, and of course, John Friedman's work is in there. Transfusion reduction, mortality reduction up to 68%, average length of stay between 16 and 33%, re-op and readmission minus 43%, complications when we talk about infection up to 80%, and costs between 10 and 24. Thank you very much.